Good evening, everyone. My name is Ware Harmon, and I'm the Executive Director of Town Hall Seattle. On behalf of our staff, our friends at the Institute for Systems Biology, and our friends at Third Place Books, it's a pleasure to welcome you to tonight's presentation of Vidya Krishnan and Amber Payne. As we get underway, I want to acknowledge that our institution stands on the unceded traditional territory of the Coast Salish people, and particularly the Duwamish. We thank them for our continuing use of the natural resources of their ancestral homeland. And we thank you for joining us for tonight's event. The presentation will run around 60 minutes, including Q&A. To submit your questions for the Q&A portion, please enter meet.ps/Krishnan, that's N-A-N, or scan the QR code right now on the screen with your smartphone. That's much more reliable than my terrible spelling. We'll drop this link in the chat as well, and you can submit your question at any time. We'll try to get to as many as possible. And as a reminder, if you want to view the program with closed captions, click the CC button in the bottom right corner of your video player. Town Hall adds new events and podcasts seemingly every day. Upcoming programs include Charlotte Cote discussing Indigenous food sovereignty here in the Northwest, David Haskell describing the evolution of sound alongside all the living things on Earth, and just announced Blaise Aguirre y Arthas and Melanie Mitchell discussing AI as it is, as it was envisioned, and as it will be, for better or for worse. Visit our website to join our email list and get the latest updates as more programs are added throughout the season. Town Hall's work is made possible through your support and the support of our sponsors. Our Arno G. Matulski Science Lecture Series is supported by Microsoft. But as you've heard me say countless times before, Town Hall is underneath it all a member-supported organization. And I want to thank all of our members joining us tonight. If you share their goal of a community energized and empowered by questions of politics, science, and culture, we hope you'll consider joining us as a member as well. Finally, you'll certainly want to go deeper into tonight's topic by purchasing your own copy of Vidya Krishnan's new book. Please use the link in the chat below to pick up yours at Third Place Books, one of our many terrific independent and local booksellers. And with that, beginning her career at the Pioneer, India's second oldest English language newspaper, Vidya Krishnan has built a 20-year career, it's that same word twice in one sentence, my bad, reporting on medicine and science, including recently extensive reporting about India's response to COVID-19. She's written for The Atlantic, the LA Times, The Hindu as their health and science editor, and for the British Medical Journal. Krishnan is recipient of numerous awards and fellowships, including a Nieman Fellowship from Harvard, studying the impact of behavioral economics on antibiotic use, an International Health Media Fellowships Award, a Global Health Journalism Fellowship from Oxford, and a National Press Foundation Fellowship, among others. Amber Payne is co-editor-in-chief of The Emancipator at Boston Globe Media. She's also a Nieman Fellow and formerly served as managing editor of bet.com, bet.com, and as executive producer of both Teen Vogue and Them. Krishnan's new book, Phantom Plague, How Tuberculosis Shaped History, is the subject of their discussion this evening. Please join me in welcoming Amber Payne and Vidya Krishnan.
Thank you so much, Ware, for that introduction. And Vidya, it's great to see you again, virtually across the world.
Thank you for having me. I will say I have a slightly unstable connection here in Goa, but we will see how this goes.
We'll see how this goes. And as I said, when in doubt, I'm just going to start reading chapter 1. If we have technical difficulties. But you know, Vidya, we got to know each other. We met as Nieman Fellows at Harvard last year, and you were always talking about TB. You were always talking about tuberculosis, and we knew that you were working on this book. We didn't really get it. We didn't really get the full scope. And kind of through the year, as we got to know you and know more about your background as a journalist, as a health and science and medical journalist and reporter, investigative reporter, it started to come together, but it really didn't come together for me until I read your book, and it's incredible. But can you just set the scene for those here with us today who don't know you? What really led you to this very deep dive, you know, this definitive social history of tuberculosis?
Well, thank you. And I apologize for just spamming everyone I know with unnecessary tuberculosis information. I've been obsessed with this with this pathogen, which I thought I have to write a biography about, because these ideas have been buzzing in my head for like a decade, and they just came in and never left. And it also came in, the pathogen itself to me had like a unique personality, and it was so individual, and I just can never stop talking about it. And my closest friends at some point asked me to stop talking and start writing, which is what I did. And I'm glad I tried to put in as much pop culture into the book to kind of get other people interested in tuberculosis. And I kind of see starting with Dracula, that's Payne is, I will say, although the readers have to judge that.
Yeah, well, let's talk about Dracula and what does Dracula have to do with tuberculosis? This would actually be a good time for you to read a passage from your book, just to set the scene for everybody.
Yeah, thank you for, I thought you'd never ask. I start the book with a very ghastly episode, and I'm going to read a portion which kind of sets the scene for what people do or did before modern science to comprehend things that are just beyond human comprehension. I'm going to dive right in. It is, okay, I'm going to dive right in. It's no coincidence that vampires, like pandemics, seem to come from elsewhere. Dracula was terrifying to urban London because he came from a remote mountainous region of Eastern Europe, alien to most citizens of England's capital metropolis. It's also not by chance that Dracula arrives in late August or September. That was also the season when cholera or bubonic plague had historically struck Europe. Like all aliens, Dracula faced a strong anti-immigrant sentiment. The Count is associated with swarms of rats and other creatures carrying filth and disease. The vampire brings a terrifying illness that thins the blood and corrupts the race. The book decries him as emerging from a whirlpool of races, which is a term Stoker from late Victorian debates when it was used to describe the East End of London, home to a large number of newly arrived Eastern European Jewish migrants who'd fled the pogroms. Their burgeoning numbers, swelling mainly in the slums, were feared to bring moral and physical afflictions to Britain. Vampires have been a part of ancient folklore long before Stoker's novel. English writer John William Polidori's 1819 short story, The Vampire, is often credited to kickstarting the genre, something Stoker may have known as a teenager when he spent hours trawling through the ancient, often illustrated texts of Irish folklore in Dublin's Marsh Library. But in Dracula, he gave the phenomena a twist worthy of the industrial age. Dracula is the son of Dracula, a word that typically means dragon, but can also mean devil. Stoker's devil lived in Transylvania and traveled to London via ship and then railroad to reach London before he began ravaging the city. Both the vampire hunters in the novel, John Seward and Abraham Van Helsing, are doctors as well as experts in vampire lore. They're on a mission to destroy the invader. During this time, medical and literary opinions were often reflections of each other. Dracula is essentially a collection of Victorian-era medical anxieties. It's written at a time when outbreaks ravaging British colonial outposts ended up at the doors of the colonizers. The most devastating example of this was the cholera pandemic of 1817, which began in faraway Bengal, India. From India, cholera went to Southeast Asia, the Middle East, and Eastern Africa through trade routes. This was the first of several cholera pandemics to sweep across Asia and Europe during the 19th and the 20th century. The plague that began near Calcutta traveled the world for 20 years, killing hundreds of thousands. The exact toll of the mortality is unknown, but some data is preserved and shows how vast the total number of deaths could have been. The British Army alone recorded 10,000 deaths, and the Indonesian island of Java recorded 1 million deaths. So to the readers in London, the devil came from the East, as was customary. Through the period of cholera outbreaks, there was an ongoing debate in England about how diseases spread, and Dracula captured it perfectly when Stoker used blood infections as an integral element in his plot.
You definitely, you start with this origin story of Bram Stoker's Dracula, which I thought was brilliant to make this really clear connection between the hysteria and the terror of the infectious disease, the lengths we've gone to historically to find a cure. You give me some sympathy for Dracula. He seems a little misunderstood. But talk a little bit about that era, you know, that era of medical discovery, and how, you know, this framework you used is still a cultural touch point that extends to present day.
Yeah, literature does this bizarre thing where it kind of gives us a mirror to understand something that we cannot understand, and that's what I found fascinating going into Dracula, and who I have a lot of sympathy for. I feel like the real guy, Vlad the Impaler, was just so misunderstood, and jumping off of that one character, which was known to evoke horror, and finding writers who combined that with the horror of just pestilence, which was very common before modern science, is such a nice, it's such a twilight zone to kind of dip into, especially because we are back again there. We are again facing a pandemic, and we're once again facing science denialism. And there is this tsunami of misinformation, which may not be very familiar in the US, but in India, it's just the last 3 years have. I finished this book 6 months before the pandemic began, and everything that came after the pandemic started has just made me realize how profoundly we need to go back to the origin story to look at things that we just take for granted. And science is a gift that we need to value as against take for granted. And that's kind of what this book does in using different stories. So through the book, you'll find a Russian doll of stories, like the stories within stories within stories. And I hope the reader finds it interesting.
Yeah, definitely. You know, you trace the spread of TB from the US and Europe in the 19th century, you know, to developing countries, and it's flourishing today. But give us just a brief rundown, you know, a state of TB today, and how did Mumbai become the epicenter and such an incubator of the disease?
So we have 10.4 million infections in 2020. The pandemic actually made TB worse because various parts of the world were in lockdown and TB patients could not access care. So things are worse than they've ever been for TB patients. Last year, 1.3 million people died of TB. And there are 3 myths about TB, and all 3 at this point contribute to spreading it. People think it's a disease of the poor and the past. Neither of those things are correct. People think that it's a disease of one organ, which is lungs, which is also not correct. TB is like cancer. In my reporting, I met patients who had TB in the eye, TB in their spine, in their intestines. And the last myth is that TB is curable. It used to be curable when we treated antibiotics with respect and used them sparingly, but there is such vast misuse and overuse of antibiotics, especially with the pandemic, that we now have drug resistant strains of TB that just do not respond to the most powerful antibiotics known to medicine. I feel like with the, yeah.
No, I mean, you talk about, you know, that you tell the stories of a few women, Pia, Shreya, you point to this, there's either a lack of treatment, over treatment, the wrong treatment. I learned about these drug resistant, you know, forms of TB. You know, I wonder how that the question is, how is that still happening? But I wanted to reference something you wrote in chapter 5 called Antibiotic Apocalypse on the Move. And you wrote, when you're talking with these doctors, listening to the doctors talk about antibiotic resistance is like hearing characters in a horror movie as they navigate increasingly limited options. One doctor joked about being at that point in the film when you realize the call is coming from inside your own house. Connect that to this issue of treatment.
In Mumbai in particular, that's how Mumbai feels like at this point. We now know because of the pandemic that a small pathogen in Wuhan has just engulfed the world. So the antibiotic apocalypse that's dawning in the slums of Mumbai for now is tightly boomeranging in that ghetto. But we now know from coronavirus that it uses that as a springboard, gets more and more variants, and then it just springboards out. And when that doctor was telling me that it feels like they're stuck in a horror movie, is because they increasingly on a daily basis see patients where we are back again at a point in history where all doctors can do is help patients die. And that is a result of misusing medicines, either completely not understanding medicine, but also India, like the US again, has a highly privatized healthcare system. So the doctors are not incentivized to give the best treatment. They are incentivized to give a treatment that retains the patient as a client. Or, if they're insured, doctors are incentivized to extract as much money from each patient. And in Mumbai in particular, all of that has added to what is now mass medical negligence, because if you're poor, you are treated without dignity and compassion, and you're undertreated. And if you're rich, you're overtreated to milk that insurance that you have. But that's also just as bad for the person. And between these two, because there's just no moderation in TB treatment, doctors in Mumbai are completely going mad looking at this. And that's what that one character was trying to say, which I will say he captured it in a very visual way by comparing it to a horror movie. That's where we are at.
Definitely. It's an important point too, I think, that you make, that it's not just, it is mass medical negligence. It's a patient killer, and it doesn't really discriminate between the rich and the poor. It's finding a way. But, we can't talk about India without talking about caste and about race and racism. You draw parallels even between caste and race, and between the system of discrimination in the East and the West. And so I wanted to talk a little bit more about that, and how TB and other plagues have been fueled by this deliberate, as you call it, deliberate architecture of unfairness.
Yeah, thank you for that question. One of the things that's not happened in India, as against, we are a new post-colonial nation. Which is why I had to lean on a lot of American literature, which has documented in granular detail the health deficits that you see in refugee communities and minority communities in African American neighborhoods. And the housing projects in Chicago are a particular study that I rely on to make this comparison between race and caste, which also I find myself in this twilight zone. I live between US and India, and it's such a unique position to be in as someone who writes about social injustice, because you see mirrors of these two completely different systems of discrimination. Race is mostly, it's just simpler because it's based on skin color and it's easily identifiable. Caste in a country like India, where everyone looks the same, is so much more insidious, but the effects of it are the same. Minority communities are ghettoized into poorer neighborhoods. And then there is poor sanitation, and the municipal services do not work in those neighborhoods the way they work in posh neighborhoods of Mumbai. And all of this leads to more infectious diseases, but also more crime. And then there is this way of talking about neighborhoods, the way, like, you attribute the characters of the bad neighborhoods to the people who live there. So, you know, the neighborhood is filled with criminals. That's a very common thing to say in India, where you talk about poorer neighborhoods that way. And I feel like it was my privilege to be able to make this comparison between caste and race, and then come down to the same point, because no matter how different these systems of discrimination are, this calculated injustice has the exact same precise impact on minority communities. They don't get healthcare, they are ghettoized in subhuman housing. And every time they are up against the health system, they are made to lose their dignity. And I use two instances in the book. The 1992 Los Angeles riots is something I talk about to make a comparison to Indian neighborhoods. But I also talk about the Tuskegee trials, where the entire country was being treated for syphilis, whereas a certain population was denied over and over again. And I kind of wanted to talk about medical apartheid, because you can't talk about infectious disease without bringing in race and caste and gender.
Yeah. That's the section on Tuskegee. I feel like I learned a lot there as well. It's a study. I feel like we know it. We hear about it. Of course, we don't get to really learn about it in school, unfortunately. But I was interested in how that fit into your exploration, and you also went into HIV and that struggle across the board, and you drew these parallels in medical history that I think are really important and really relatable for all audiences. But I want to get, going back to the drugs, to squash this global health epidemic. TB, start with TB. There are other issues. What did you learn? Can you give an example of something that you felt was important to really dive into in the book? And I want to get to just the question of how do we reform the drug industry, but let's talk about these drugs and the issue.
I live between US and India, and I've been a health reporter for so long, and India is the pharmacy of the world. But what we now do, what our generic industry now does, is basically manufactures drug at a fraction of a cost for American pharmaceutical companies. So, for example, Pfizer will outsource the drug making to India, make it at a fraction of a cost. The drugs will be exported back to the US, where they slap charges on it which are just not justifiable anymore. And one of the things that I hope it's a conversation the book forces is that the global drug pricing conversation cannot be had in silos. Cancer patients are fighting for access to cancer drugs. TB patients are the same. Now with COVID technologies, and we keep having the same conversation, disease after disease, whereas it's one conversation, the patent monopolies that are enforced on the rest of the world, because when these laws were drawn up, the colonies, which is the global south, the developing nations, the G77, were not a part of this. We were not invited to the negotiating table. And one of the things, we cannot talk about drug pricing without calling into question the moral, the morality that guides it, because we keep having, I keep reading literature where it says that, oh, this is not a cost-effective intervention. So my country is a low-resource country where you need medicines that don't depend on, say, cold chain, or because we don't have a robust health system. Anyway, it's a long, winding way of saying that who decided to have a conversation about right to health in economic frame? I don't know who decided at what point that it's okay to let people die unless someone or some company can turn a profit. Essentially, the moral reasoning underlying this economic framework is that they'll not save Black and brown people unless it's profitable for them. So in health, we keep talking about cost-effective measures as against effective measures.
Right.
And there is just mind how unjust. It's just unjust. It's unfair. And it is racist. And there's no way of beating around the bush. So one of the things this book does is decenter this conversation of medicine as a knowledge monopoly to the point of view of Black and brown nations. And that's not been done before. And I was very, very conscious of using TB as an example, but the same thing applies. This book was written before the pandemic began, and I didn't have to change a single thing. What we now see with the TRIPS waiver and patent monopolies, everything that I write in the last few chapters of the book has come to pass. And it's been very frustrating to watch that.
Yeah, it's prophetic. Because you draw this direct line too between colonialism and patents of these pharmaceutical drugs and technology. So I wanted you to sketch that out for us. You spend a great part of that, great chapter really explaining the issue with the patents. So can you sum up the issue with patents and TB drugs?
So this again came from this frustration of being an Indian reporter, and we make drugs for the world. And while we are constantly told by Western pharmaceutical companies that the quality of drugs in African and Asian countries, if they're manufactured, is not good and we can't trust it, but they can totally trust it when they outsource all their clinical trials to Black and brown nations. And which is why I felt like writing a book kind of gives me the scale to deep dive into the story of the origin of intellectual property law, which began with the English and the French Empire in 1883, when there was a scramble for territories in Africa and Asia, and the empires wanted to regulate trade. And what we see as TRIPS is a 21st century legal inheritor of these laws. And India, again, as the crown jewel of the British Empire, had an intellectual property law long before most European nations. We had one in 1856. And all of this kind of comes from a very unsettled global South, where they can only manufacture raw material and export it, but they cannot ever demand equality. And the TRIPS laws, as well as the laws framed in the late 19th century, were framed with the intention to load the dice in favor of the empires. And they currently load the dice in favor of multinational corporations. Intellectual property historically has been a tool to promote trade interests of the developed nations in developing countries. So when India was invaded, we were manufacturing, we made textiles and ships and all of these silk and spices. But the minute British Empire came in, they reduced us to a raw material. British textile industry could back to the roots of this, saying this has always been racist. It's not just suddenly racist now.
Right.
And I hope, I mean, it's not a coincidence that most people from the pandemic are dying in Black and brown nation. This is now a preventable infectious disease, coronavirus. We have 12 vaccines. And in my country, you can't get a booster shot as yet. So.
Wow, it's maddening. And we're going to start to take some audience questions. Please, everyone, feel free to continue to submit questions. But I do need to ask about Bill Gates and the Gates Foundation, huge nonprofit. they've given out 60 billion in grants since they began. Last year alone, they funded work in 134 countries. They're revered in this space of health equity, research development, funding. But to quote you, you write that Bill Gates has, and I quote, the mind of a genius and the morals of a thug. Let's talk about it.
Thank you for that question. So India is the largest laboratory for the Gates Foundation. And my entire career as a health reporter, I've interviewed Mr. Gates quite a few times. And I've been hearing my entire career that Mr. Gates wants to solve malaria. Here's a disease with coronavirus that Mr. Gates can solve. But what he did was the Oxford University funded vaccine, which was funded by taxpayers. He handed it to an Indian company, the Serum Institute, as a patent monopoly. So only one company in India could manufacture the drug for the rest of the world. And it doesn't take a genius to point out the flaw in concentrated supply for the world and the kind of burden it places on India. I don't know if you remember the devastating second wave that India had 6 months ago, and that choked the vaccine supply to 91 developing countries. And all of this is because Mr. Gates is one of the champions of knowledge monopolies. And for the life of me, I cannot wrap my head around how they keep talking about these complicated ways to get vaccines to poorer countries, when the simplest and the most direct way is to transfer technology and let these nations manufacture it for ourselves, as against manufacturing it and exporting it to them. And I'm going to quote, I do quote Nigerian poet and author Chinua Achebe in the book, who says, charity is the opium of the rich. And that's the crux of what the Gates Foundation's again, the moral underpinning of this whole way of making healthcare available is philanthropy cannot fund healthcare. And again, it comes from a completely unsettling view of the developing world. I do feel that the West is just incapable of looking at the world without giving itself the role of the savior. And we keep coming back to, we saw this during HIV, where drugs did not get to Africa, which is where the most deaths were, because the minute you elevate charity to some high principle of justice, what you're not talking about is the profits the companies are turning. And the Gates Foundation needs to come under scrutiny, I believe, mostly because their charity is toxic kindness. What they get from that charity is this position of superiority where they dictate the terms. At this point, Gates Foundation is the largest donor to WHO. Gates Foundation also hires CEOs of pharma companies on its board, and there is too much clash of interest. And this is a man who's not elected to public office. He's not a scientist. He's not a doctor. Yet he has so much power and no one questioning it. And that's, again, kind of something I wanted to complicate in the book. And thankfully, I did have publishers who were okay printing that sentence that you read out to me.
Yes. Well, yeah, thank you for breaking that down. You have this example in the book too of an HIV drug that was going to be given for free. Can you just share, kind of sum up that moment and how that actually proved to be a watershed moment for HIV drug pricing?
So when the HIV drugs, at some point, the HIV drugs were not available in Asia and Africa because they were priced at of $10,000 to $15,000 per patient per year. Now, most people, even in the US, cannot afford it. And I go into how this HIV drug was entirely funded by American taxpayers. But what happens is the entire portion that is the research and development of a drug is subsidized either by universities. Most of the drugs in the last few decades have come out of universities that are taxpayer funded. But the minute they get the potential to get to the market, the molecule is acquired by a pharma company, and the social role of this fruit of medicine is withheld, and the singular purpose of this becomes turning profits for pharma companies. With the HIV drug, what happened, this is AZT, is that an Indian generic drug maker, Cipla, offered to make that drug for $1 a day. And it was, the New York Times called it a watershed moment. The prices came crashing down and Big Pharma had to readjust its prices. So they were literally charging $15,000 for a drug that costs $350 per patient per year. And that's after, this is early 90s, and around the same time, the TRIPS laws, the TRIPS agreement went into force in 1995 to make sure that something like this never happens. The company Cipla was headed by a brilliant doctor called Yusuf Hamid, and American pharmaceutical CEOs at that point called him a pirate and a thief for making the drugs available at cheaper rates. Whereas in Africa and in Asia, he's known as the Robin Hood of drugs. And, wow, this whole conversation, as someone who lives in the global South, and my career has been writing about infectious diseases and watching people die like flies, I felt like there is urgency to decenter this conversation to the point of view of the developing world. And that's kind of what I try to do when I extensively talk about the HIV movement and people who died from HIV. We don't need to keep making that mistakes where millions of people have to die to convince someone sitting in the developed world to part with technology, which doesn't even cost money.
Right. That's a great point. We're going to go into some of our questions in the chat. There's one question here. We have been so aware of the COVID vaccine disparity between rich and poor nations. Are there a lot of other vaccines that this is the same problem for, and we just haven't acknowledged it?
Yeah, absolutely. So cancer drugs is a big problem. TB drugs, I go into the book about a drug called bedaquiline, and that drug is a genuine example of public health communities coming together, passing the hat around to fund R&D of a drug that was just desperately needed. And the minute the drug became available, it got locked into patent monopolies. Hepatitis C has a drug called sofosbuvir. Egypt is one of the countries very badly affected by Hep C, and this drug, gram for gram, is more expensive than gold. And one of the things, again, with COVID, we see the same things. These are taxpayer-funded drugs. We have 12 vaccines. One is funded by German taxpayers. Some is funded by Indian taxpayers, American taxpayers. And we just are greedy and don't want to share. And it keeps coming back. One of the things that I watched with great frustration, especially in the US, where someone like Bernie Sanders talks about right to health, and he's called radical and leftist for saying the most commonsensical thing. And the conversation about access to medicine and right to health is a global one, because what we have is a global oligopoly of a very few pharmaceutical companies, all of which are based either in the US or in UK or Japan. And unless the patients also start having this conversation as a global one, we cannot hold this system to account. And for me, all of it begins with the patent law. We cannot have drugs regulated legally the same way we regulate iPhones or refrigerators. It's just not same.
Yeah, yeah. Our next question, going back to the discussion on Gates, are you suggesting the WHO and global health would be better off without Bill Gates' financial contributions? What is anyone else doing in the US that is making a tangible difference?
This is a complicated question. But if I have to say, yes, the global health will be better without philanthropy being the fundamental source of funding health. So WHO can have a global kitty. Again, with medicines and patented medicines, there's something called the medicine patent pool, which is an idea of Mr. Jamie Love, who's based in DC. It's a global north idea, but I give this out as an example that there are 100 ways to fund global health. This one, the medicine patent pool, says that countries can pool together the money to buy the patent from the innovator pharmaceutical company and then give it to countries so they can then manufacture drugs for whatever, like for TB or malaria or whatever, and to contain infectious diseases. But the thing is, pharmaceutical companies are not ready to sell the patents, even at a reasonable price, because they don't want to open their books to say exactly how much they spent researching a particular molecule. What they say is this one molecule has to pay for all the failures that came before us. Now, I answer only for the drugs, but with WHO again, WHO is not an American organization. But what it now does, the New Republic had a brilliant essay where it said that, and I quote it in my book, that what we see is a hostile takeover of WHO by the Gates Foundation. The minute an organization like WHO becomes monogamously faithful to certain philanthropic organizations, it comes at the cost of Black and brown national health. And these are the reasons why global health has never been this vulnerable. We are at a point where we have many challenges from climate change and multiple infectious disease pandemics, and they are all on the move because of global trade. And the sooner we get to the point that we have to stop making heroes out of singular people, as against the Gates Foundation for years has thrown money at Indian problems, but none of them have found structural solutions that make Indian hospitals better, because then that means that it'll shut the shop. The fount of injustice means that there has to be continued wretchedness in poor countries that then big philanthropy can come and help. And the biggest example of this was this just devastating second wave. India has never seen deaths like that, and we will carry intergenerational trauma from that. Where did all the money Gates Foundation has invested in India go? It's a question to ask. So yeah, short answer is Bill Gates is not the solution to our problems.
Okay, thank you for that question. Here's another question. You have been brainstorming this book for years. What was the real push that inspired you to start? And how has your research or perspective changed since then?
Well, I wish I had an answer that was not just so revealing of me. I was reporting on this book as a news story, and I write about this one teenage girl who had to go to court, and that kind of shook me and my idea of India, because we are a democratic country, and I said we are a pharmacy of the world, and I just still cannot reconcile that my government and my health ministry let this teenager die because we kept denying her this one drug, bedaquiline, which was locked under patent, and they wanted to protect the patent of an American company. And this teenager is an example of how all of these families are getting just destroyed. And I kept reporting it as a long form essay and news story. Eventually, I had friends who did an intervention. And at that point, I had around 25,000 words written, and I was refusing to commit to it as a book. And they made me realize I had a book, and a friend made me write a book proposal, which I did very grudgingly. But then I did find a publisher, and then I had to act on it. And how has the book changed me? I kind of feel the one thing that I learned while reporting on the book, because I also did end up spending a lot of time in the US, is that we need more Black and brown solidarity. I realized how calculated the injustice is. When I was just in India, I had a very smaller view of how the system was just not set up to serve the poor. But when I did spend time in the US and during the pandemic, even in the US, Black and brown communities have different rates of mortality for the same living in the same cities. And it kind of made me realize how we need one unified voice if we are to talk about right to health. And I really hope the book achieves or conveys that message.
Thank you for that. Another question we have is, what is the biggest myth about TB and what should everybody know?
I will say in my reporting, people are traumatized. I have had friends who report saying that I had nightmares that I had TB. And the biggest myth about TB is that it affects just the lungs. And I write in the book, which is why I do not focus on patients with pulmonary TB. I write about one kid who has TB in her ankle bone, and TB in the brain, TB in intestines. And I kind of don't, it's not on the nose, but that was my reason to over and over again profile patients who had TB not in the lungs, because outside of the medical community, people don't realize that TB is exactly like cancer, and the chemotherapy is exactly as toxic as cancer. So, yeah.
Yeah. Another question. I'm a nursing student at the U of W. Which department, office, person do I contact to actually contribute to global health? I'm frustrated because so many health clinics in my hometown throw away expired doses of vaccines.
Yeah, yesterday I was reading about how Canada is just going to bin millions of COVID vaccines, and I believe, again, I do not know the structural solutions in the US or Canada as much, but I am a sociologist by training, and I do believe that the solution to this is in the politics of it. Contacting your local representative is one way to start, because these vaccines are desperately needed in Asia and Africa, and it boils my blood to watch it just expire, or when I have lost so many friends and family members in the last 2 years who would have lived if if we just learn to share and be kinder to each other. And I do believe the solutions for this medical problem are political.
Mm-hmm. Connecting to COVID, I wondered if you could talk about how COVID has turned TB into a bigger threat and what can be done about that.
So in countries, in high burden countries, which is India and South Africa are two of the countries with the highest burden. What happened with COVID in India in particular was terrifying, because we had a brutal lockdown, which then meant that patients could not reach health systems, get their medicines, and which then meant that they developed resistance, which also then meant that because they were locked in with their families, they spread that disease to their loved ones. And it has been heartbreaking I keep getting emails from TB patients saying, I'm terrified I'll infect my mother, and all of these things have actually also resulted in a dip in because people were not reaching the health systems were not able to count better. So I kind of feel that the next couple of years will see a increased uptake in mortality. But I do believe there are opportunities here, like something like the NHS was born out of the World War, and every crisis is an opportunity. And I am optimistic because while TB doesn't have funds, COVID is overflowing with funds. And respiratory diseases have never had this kind of attention. And the technologies that we use to diagnose COVID can be also used to screen for TB. And there is a way to kind of merge programs the same way as many countries merged HIV and TB programs to screen someone who's coming in with HIV to also screen them for TB because they're likely to have an opportunistic infection. So these are all structural solutions. But I do believe in the next couple of years, if health systems and again, health ministries and politicians are more responsive and open to change, we could look at curtailing this, because again, mask wearing has been destigmatized in ways it has never been before. We are also having a very loud and very voluble conversation about anti-vaxxers, but it is an opportunity to address science denialism. So there is opportunity within all of this. I remain hopeful.
That's, I didn't expect you to say that. But
not, it's very off-brand for me, but I do remain.
It is off-brand. But no, that's real. That's realistic. We have a question, and we just have time maybe for one more. So if anyone has anything, please get it in there. What have the reviews of your book been like in India versus the US? Do you find both parties are picking up on certain things?
The book has not been released in India as yet. It releases on the 1st of April, and I am very nervous about it because we also have an authoritarian government, and everything that you read that became the book is a compilation of stories that I was not allowed to report for the newspapers I was working for. So I remain on edge about the reaction in India. The reaction in the US, I will say, makes me, again, as someone who, I know my American friends and my American journalists get very frustrated with the growing intolerance in the US. But someone like me, a rank outsider, would not be allowed to make such a strong commentary about the US, but also about India. And the New York Times had a very flattering review, and I am thankful for it. I do hope, this is why we expect more from the US. We expect more, we believe in democratic structures in the US, because something like that, for example, Amber cannot come to my country and have such a critical commentary on something uniquely Indian. And I am glad that that is allowed in certain bubbles, and I'm glad I have the privilege to have one foot here and one foot there and kind of juggle a bit in this space. So yeah.
Yes, but countdown to April, April 1st. I wanted to ask, I didn't get to talk about the caste equality movement. We talked about caste a little bit. And in your book, you describe how it was inspired by the civil rights movement in the United States. Can you share about that?
Yeah, thank you for that question. I am a geek. I nerd out on civil society movements. So it's such a unique parallel between India and the US, because Dr. King was inspired by Gandhi. He came to India and said that he visits most countries as a tourist, but to India he comes as a pilgrim. And he went back and he launched the Montgomery bus boycott, which then inspired the HIV movement, which then inspired many global health movements, but also in India in 1972, something called the Dalit Panthers was set up, which was inspired by the Black Panthers. And there is such, which is why I believe in this intersectionality and the need for Black and brown solidarity across nations. And these parallels between India and US is such a beautiful but fragile relationship between East and the West. And it was a complete privilege. I was surprised that it's not known enough. And I was very happy to then include it, because the caste apartheid in India is entirely in keeping with the racial etiquette of the Jim Crow era or the apartheid era in South Africa, but very few people know about it. And we kind of need to, the medical apartheid, we talk about race and how it impacts in many other ways, education, for example, but we never foreground it in conversation about access to health movements. And I take this tangent and I meander into this to kind of foreground this conversation.
Yeah, I think your Russian doll example is a good one. Just the journey that we go through the book, and it's all interlocking, it's all interconnected. I think you really weaved the story together well, and it works in these different parts. Last question for you, just, you did touch on leaving with some hope, but really, what do you hope the takeaway is from your book?
I really, the book ends with a very strong, full-throated call for entirely disbanding the current intellectual property regime, or having it renegotiated such that it gives equal value to Black and brown lives, and not just foreground controlling diseases in Black and brown countries, as against caring for the patients who live there. So I do hope, if there is one takeaway from it, or two takeaways from it, I would like for these toxic medicines for TB that are making patients go deaf, but they are being used because newer medicines are not available. I really hope if WHO or governments are listening, they phase out injectables that are toxic. And we also have a conversation that is more realistic about the intellectual property laws, without accusing people of being too emotional, or when they bring it up. We need to, it's not an easy conversation to have, but we need to have it now.
Well, thank you so much, Vidya. It was a pleasure and honor to talk to you about your book, especially since you and I and our other fellow Neiman, Sam, made a trip to Mercy Brown's grave. Want to explain who that is real quick?
So Mercy Brown is the inspiration for the character of Lucy Westenra in Dracula's novel, and she remains buried in Chestnut Hill Cemetery in Exeter, Rhode Island. And I'm lucky to have friends and my Neiman family, who at the peak of the second wave, when I was in Boston, took me to the graveyard to cheer me up. And it did the job. And I hope you pick up the book because there's lots of pop culture, and it is about plague, but it has a lot of gallows humor.
It does. Phantom Plague, get your copy. Thank you so much, Vidya. Back to Town Hall.
Yes, thank you so much, Amber, for leading this conversation. It was so nice to have you here. And Vidya, thank you for calling in from your beautiful location. Thank you for zooming in with gloomy Seattle tonight and educating us on your beautiful book. And I am so excited for your launch in India. I know it's going to be great. It's going to be perfect. And I'm so excited for you.
Thank you so much. This is such a pleasure to talk TB.
Yeah, this was wonderful. Thank you. And to my friends at home, please remember to purchase a copy through our friends at Third Place Books, and that link can be found in the chat. From all of us at Town Hall, have a great night. Thank you.
Thank you.
Thanks.